Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Welcome back to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, board-certified OBGYN and REI, which means I'm a fertility doctor, and one of my passions is to help you understand your fertility better. So today we are going to do just that. This is one of my favorite episodes. This is where I'm answering your fertility questions. If you would like to call and leave a voicemail to be featured in a future episode, go ahead and call the voicemail at 657-229-3672. Again, that is 657-229-3672 for the As a Woman voicemail. Leave any question you want, leave your name or don't. It's up to you. But sometimes people don't even know what questions they have until they hear you ask your question. Today's episode is all about the things I wish you knew. Questions you have about fertility, whether it's now or in the future, that can be really hard to get the answer to. Before we jump into answering these voicemail questions, which are so good today, a few other housekeeping items. One thing is that you can ask questions in many different ways, so maybe you're not a leave a voicemail kind of person. You can also leave questions on Instagram at nataliecrawfordmd. On Monday, we answer your question. So you'll see a question box in the stories on Monday. Feel free to go and leave your question. Some will be answered right there on Instagram. Some will be answered at the end of our regular podcast episodes, and some will be answered in the newsletter. In addition, you can sign up for the newsletter at nataliecrawfordmd.com/newsletter. And in the newsletter, what you will find is updates, which are going to include some very fun surprises and freebies for newsletter subscribers soon, recipes, and also a place for you to ask special questions there that have a higher chance of getting answered. Because we get thousands of them on Instagram, it's still a great option, but leaving a voicemail or asking a question through the newsletter link are going to have a higher yield of getting that question answered for you. I've got so many fun surprises and exciting updates coming. I can't wait to share all of them, but let's dive on in and answer these questions because you guys have some really great ones today.
Hi, Natalie. My question is about the cystic fibrosis gene and male infertility. I found out when I got pregnant that I carried the gene. It was quite a shock because no one in my family has ever had cystic fibrosis. But I spoke to a genetic counselor. My husband was tested and did not have the gene, so I was told I didn't need to worry about it. But it was only through your podcast that I learned about CBAVD. And now I've got 2 boys, and Google is telling me almost nothing about it. And I was hoping you could help me understand what to tell my sons about how to broach the subject with their doctors someday. There's a 50% chance that each one of them has the gene, and so I definitely need to have a talk with them at some point about getting tested before they get someone pregnant for sure. But the information is so hard to find about possible infertility. How common is it among male carriers? When should they bring it up to their doctors? Should I start talking to their doctors now when they're tiny? Will insurance cover genetic testing and then their sperm analysis because they know that they might carry the gene? At what age should they start talking about it? You know, they're tiny now, but there is just no information online about this, and any information you can or insight is really helpful. Thank you.
This is such a great question, and there are so many confusing bits about this. So to catch everybody up, CBAVD is congenital bilateral absence of the vas deferens. In male anatomy, the vas deferens help connect the testes where sperm is made to the ejaculatory system. So importantly, men who carry a cystic fibrosis gene have an increased risk of not having vas deferens. This is a birth defect, so just being born without them. Now, if you have cystic fibrosis, the disease, you have 2 copies. Let's remember that cystic fibrosis is what we call an autosomal recessive disease. This means that you have to inherit a copy of the gene from one parent and a copy of the gene mutation from another parent in order to actually be sick with cystic fibrosis. So if you are a CF carrier, like this person, they'll test your partner. And if your partner is negative, you will be told, great news, your partner is negative. You don't have to worry about your children having cystic fibrosis. True statement. True statement. Now, what they don't talk about is what potential impact it could have on your child's reproductive life or your grandchildren, because your kids may want to have kids one day. That being said, if your partner did in fact also have a copy of the cystic fibrosis mutation, and we find that in about 3% of all couples who we test, this would be a circumstance where, number one, if you were pregnant and found this out, you might talk to your team about getting prenatal testing to see if your baby would have cystic fibrosis so that you could have supportive treatment the best, or have the opportunity to meet and discuss with specialists or make a decision that's right for you. We are big believers in preconception testing where I come from, meaning I want to see you before you get pregnant. Let's not treat a problem, let's prevent it. And if you and your partner both carry the cystic fibrosis mutation, we should have a really strong talk about IVF with genetic testing, and specifically what we call PGTM. PGTM is pre-implantation genetic testing for a monogenetic disease. This means that we can take a few cells from an embryo and send those cells off to look for a single gene mutation. It's really amazing technology and can be life-changing if you have a disease that runs in your family. Thankfully, in the circumstance, we don't have two CF carriers, so great. So now we're at the place where we have two boys and we know that we're a carrier. And what does this potentially mean for our children? Now, number one, if you did have cystic fibrosis and you're a male, you have two copies of the genes, you now have a 95% chance of having CBAVD, very, very high. If you are a cystic fibrosis carrier, so you just have one copy of the mutation, now you have about a 44% chance, so pretty high. What does it mean to have CBAVD? You make sperm, but it's not in the ejaculate. It just can't get there. There's no connecting pipe. This means that in order to get pregnant, you would have to have a testicular aspiration procedure. There are different options for how this is done, but the short answer is that sperm is taken more directly from the source, and you don't need it to go through the vas deferens. So you take the sperm from the testes themselves. That sperm is only going to be enough to use in an IVF scenario, but you can then fertilize eggs with that sperm in IVF. So our worst case from our own child who might have a CF gene would then be that they would have a 44% chance that they could have CBAVD, which would mean they wouldn't be able to get pregnant naturally without IVF. So maybe a little IVF fund if they end up having the cystic fibrosis mutation. Now, when should you find out if your child should have this, and what does it mean for their reproductive future? Because you also can't guarantee that they will have CBAVD until you have a semen analysis. One is that you should 100% tell your children that they might have a high-risk gene mutation, and that when they are ready to have a family, they need to have carrier testing themselves and their partner. I honestly think this will be very standard when that generation is of reproductive age. But if it is not, it is something that every OBGYN, every fertility doctor can do. It's a blood test. It is very easy. Is there any reason to do it now? Not in my opinion. I don't think knowing that information now would make any difference. However, knowing your child is a carrier when they are at the place in life when they're ready to be in a committed relationship and have a partner and have kids, yes, because one, if they have no sperm in the ejaculate, they need to do IVF. The sooner they do IVF, the better when it comes to female partner age. So even if they don't want to have kids till they're 35, if they are with this person at 24, then starting their IVF journey at that young age will make a very, very different story than waiting till 35. Especially because we have to deal with two things when it comes to genetics. You have the normal rate of aneuploidy, or genetically abnormal embryos, that we know increases in age as women get older. At 35, about half your embryos will be normal and half will not. Then, though, you're going to lose some embryos to cystic fibrosis potentially, depending on if that person's partner could be a carrier too. So things to think for would be one, have your child tested when they are in a committed relationship. If they don't carry the CF mutation, no worries. If they do, consider getting a semen analysis, because if they have CBAVD, you'll see zero sperm in the ejaculate, and then that will be a circumstance to talk about IVF and what should happen. If they have sperm or don't have sperm, but they have a partner, should definitely have the partner tested for carrier testing as well if one of your sons is positive, so you can prevent having a grandchild who could be sick and have cystic fibrosis. As for insurance, the landscape is changing dramatically, so I'm not going to crystal ball what might happen in 20 years. But historically, no, insurance has not covered semen analysis, IVF, or genetic testing, even when there are clear medical indications to do so. We can sit here and hope that will change, but the truth is, only time will tell.
Hi, Dr. Crawford. My name is Katie, and I just want to say thank you so much for, everything you do and your podcast, taking the time out of your, I'm sure, very busy schedule to inform and educate us and answer our questions. So my question is, I am 32 years old. My husband and I are beginning the process of IVF, and I recently found out through an HSG that I have blocked tubes as well as hydrosalpinx. After my doctor reviewed everything, he is not recommending surgery to remove the tubes or to fix the hydrosalpinx. He is recommending to just aspirate the fluid before we do an embryo transfer. And I feel a little bit like that's not the right protocol. Everything I've read online and anyone I've spoken to has said that surgery is pretty much the standard for how to treat a hydrosalpinx before IVF. And so I was just curious if you had an opinion on that, if you've heard of just aspirating the fluid, and if you have, if that tends to be successful. So yeah, thank you so much for your time.
Katie, hi. Thank you so much for all your sweet words and for listening to the podcast, for calling in, leaving a question, and for supporting this passion of mine. Friend, the way my jaw hit the ground when you said your doctor wanted to aspirate the fluid, I cannot. Now, let me clarify. Versus nothing. If the option is nothing, aspirating the fluid is better than doing a transfer with the hydrosalpinx in place. However, I'm going to guess that's not the case in this scenario. So a hydrosalpinx is when the end of the fallopian tube is blocked, therefore the tube becomes damaged, dilated, and fluid accumulates. I like to think about this fluid like it's toxic, like yucky pond water. And if you can imagine, it can't go out the end of the fimbria. The end of the fallopian tubes no longer allow any of that fluid to go out because they're blocked. So what's going to happen is that fluid is going to back up. And that fluid then in the fallopian tubes is going to lead us to be in the position where it'll leak back into the uterus and decrease pregnancy rates. So transferring an embryo in the context of a present hydrosalpinx decreases success by 50%. So we know that's not ideal. Now, the options are to remove the tube, salpingectomy. That is the gold standard. Number 2, also very good, is what we call proximal tubal occlusion. So burn the tube, cut the tube, put clips on the tube, but essentially what we're doing is disconnecting that hydrosalpinx. Now it's still sitting in your body, so now it's just blocked on 2 ends and it's just a dilated tube, but the toxic pond water, for lack of a better word, is now not leaking back into the uterus. So salpingectomy versus a proximal, the opening of the fallopian tube occlusion, are both standard and accepted approaches. Now, to answer your question about aspiration, number 1, when might you do that then? If these others have been studied more and shown to be the best, why on earth would you just put a needle in and drain out the fluid? This has happened one time in my career where there was a patient who had terrible pelvic scarring, meaning when we put a camera in through her belly button and looked below, you could not see her fallopian tubes, her intestines, her bowel was all scarred to the hydrosalpinx, and the risk of injury, intestinal injury, colon injury was too high, and there was no way the tissue planes no longer existed to remove the tubes. Now, these are very rare scenarios, typically with very severe inflammatory disorders like very severe endometriosis or having had some prior pelvic infection. This patient had had peritoneal chemotherapy for cancer in the past. So obviously her internal anatomy was just not normal. In that situation, my options were nothing or aspirate the fluid. So that's a circumstance where aspiration is better than nothing. Now, we also used to have Essure, which was a coil you would actually be able to put hysteroscopically. So the patient like this would be perfect for, and it's not available in the US, but in other countries it still is. And this would mean hysteroscopically, I could put a camera inside, and now I could put this little coil, think of it like an IUD for your tube, and it would scar the opening of the fallopian tube so the toxic tubal fluid could not come into the uterus. So that also was an option that helped achieve proximal tubal occlusion. But if you can't operate on somebody, since I don't have that, I don't have the option for Essure here in the States, my choices are to do surgery. I've got to put a camera in your belly button and other laparoscopic ports and either take out the tube or be able to proximally occlude it some way. If you're not a good surgical candidate, there are a few reasons why this could be the case. Maybe you have a really bad medical problem. Maybe you shouldn't be getting pregnant if that's the case. But if your BMI is over the limit of the surgery center, if you've had multiple abdominal surgeries in the past, if we know your anatomy is distorted, those are cases where you'd have to have this discussion. However, I'm suspicious that this is a case where maybe our doctor doesn't have a surgery center or privileges anywhere, or it takes a while to get into a surgery center, yet they have a very big needle that they aspirate cysts and follicles all the time in their IVF lab. And so to this person, it's faster, easier, and they can bill more for this aspiration versus doing the proper procedure. There was a meta-analysis looking at these different options. So looking at aspiration versus nothing, proximal tubal occlusion versus nothing, salpingectomy versus nothing, and then looking at them compared to each other. The take home is it's very clear salpingectomy and proximal tubal occlusion are the best options. They are better than aspiration. They have lower miscarriage and ectopic rates. They have higher ongoing pregnancy rates. Aspiration compared to those had lower rates. People had a less likely chance of having an ongoing pregnancy than in one of the other ones. However, versus nothing, hydrosalpinx in place versus aspiration. Aspiration is better if you are not a candidate for surgery. So I would ask some questions about why not surgery. Is it truly just an access thing? A lazy thing? I know I hate saying that about other doctors, but it's so far off the recommendation without you giving me information that might lead us to believe that we're not a good surgical candidate, that it's definitely a red flag. So ask some questions, and when in doubt, get another opinion. Lots of love. All right, time for the next question.
Hi, Dr. Crawford. My name is Jenna. I'm a 29-year-old medical resident. I just froze my eggs yesterday. I've been thinking about it for a while, and you ultimately convinced me to do it, so thank you so much. I was just a little bit confused by the results I was given, and they got 17 eggs out of me, which is so exciting, and I was very happy about that because my egg matrix was kind of low, and they didn't really know what to make of that. But only 11 of them were able to be frozen. I was told it was like a maturity issue, that they weren't really sure, and the doctor was surprised that they didn't freeze more based on the eggs that they saw inside of me. I was trying to interpret it as like a medical professional myself. Obviously, I'm not an REI, I'm in internal medicine, and I'm already getting kind of fearful that one day I'm going to have trouble getting pregnant and not have enough mature eggs. And I know this is probably very complex, but I just figured I would reach out with a question. Thank you so much again. It's because of you that I now have 11 eggs frozen in the freezer for me to use at a later date. So I'm so excited. Thank you so much.
Hi, Jenna. I am so proud of you that you froze your eggs. You just don't even know how much you have opened the door of opportunity. And even if our cycle might have been less than ideal than we had hoped, it doesn't mean by any means that it was bad. 11 mature eggs at age 29, fantastic. But why did they retrieve 17? Why were they measuring more follicles? Why do you only have 11? This is a great question. So first of all, it's really important to understand that what we're trying to do when we do IVF or egg freezing is stimulate the ovaries to allow all the eggs that exist in that month to grow. Remember, every single month you have a group of eggs released from that vault inside the ovary. The number of eggs that are available each month correlates with how many you have remaining. So in general, the younger you are, the more you have, and the older you are, the less you have. But everybody is going to have less over time. And so when you start to have less eggs inside the vault, fewer come out per month. Each egg grows inside a follicle, so even though we can't see the eggs really, we can see the follicles on ultrasound and get a follicle count. What we expect for your age range to be average would be around 20 eggs outside the vault in a given month. So 17 is actually very close to that. You did mention that you had a lower AMH, so 17 was a little bit on the high side for what they were expecting. And it's important to tell everybody that AMH can be influenced by a few hormonal situations in your body. This can be prolonged birth control pills, especially if you're taking them continuously and not having a period. Similarly, sometimes IUDs can do this, especially if you're not ovulating. Things like Implanon or the Depo-Provera shot, these can all suppress the production of AMH from our follicles. And they actually can make it sometimes a little bit harder to get the response you want if you've been on prolonged contraception going into a cycle. But every person's going to be a little bit different on that one. Other scenarios where your AMH might appear lower than what reality shows is when those ovaries have been suppressed. So this namely can be after prolonged treatment for potentially endometriosis, things like Lupron or norethindrone, or being pregnant recently, being in the postpartum period, or breastfeeding. So just FYI, the cells that surround our follicles are hormonally sensitive. Now, what I'm trying to get your body to do when I do IVF or egg freezing is not something your body wants to allow. Your body doesn't want to have 20 babies at one time. So its protective mechanism to prevent that is to not allow me to have 20 follicles grow. Because what is happening is as we're giving medication, we're trying to get as many follicles as possible because the more follicles we get to maturity, the better. But at the same time, your body doesn't want to let this happen. So there's this internal conflict. Remember that naturally or normally, what's going to happen if you're not on any contraception? Group of eggs all come out of the vault. Each egg grows inside a follicle. The brain sends out follicle-stimulating hormone, or FSH, just enough to get that one follicle to grow, that one egg to mature and ovulate. And the next month, you have another group. Now, I correlate this with a terrible analogy, but if you can imagine, you have a nest of baby birds. And what is happening is normal ovulation is mommy bird is bringing that one worm to the nest. Whichever bird is the biggest is going to push the others out of the way and come up and eat the worm. And it's going to always eat the worm first. And it's going to fulfill the prophecy to become the biggest bird. That's what happens normally. One of your follicles leads the way. The FSH receptors are on the outside of the follicle. Bigger follicle, more receptors, eats up more of the medication. It grows to maturity. That's the one you ovulate. My absolute favorite analogy for how I like to try to do with ovarian stimulation for IVF or egg freezing is to suppress the body and then stimulate it. Meaning, if I starve all those birds and there is no big bird, there were no worms coming in and everybody's hungry, and then I come and dump a tray of worms in that nest every single day, all my little birdies are going to eat at the same pace and they're all going to get a little bit fatter every day and they're going to grow to be big at the same pace. That's what we want to do with ovarian stimulation. So I really like to view it suppressing your body and then stimulating. The stimulating is pretty much the same. That is mostly FSH. So these compounds are synthetic in the lab, Follistim or Gonal-F. Sometimes, depending on your protocol, you'll also have a medication called Menopur, which is an LH-FSH combination. And this is actually purified from the urine of menopausal women, but it's the only LH compound that we have. So that's pretty standard, but the suppression can really differ. One, some people don't suppress. They're going to say, hey, Jenna, call me with your period, and I'll bring you in for a baseline, and we'll just start the FSH. No big deal. That is quite common because I can get you into cycle faster, take more money, get you out of there. And if I'm not concerned, I might not get your full potential, and maybe that doesn't really matter to me. It matters to me, actually, quite a lot. So I rarely do a spontaneous start. Exceptions are going to be cancer patients who have a very strict timeline, or patients who really aren't good candidates for suppression. Maybe they have a contraindication to oral estrogen, they have a clotting disorder, an estrogen-sensitive cancer. So there are a few exceptions. But for the most part, it's better if we don't just spontaneously start, in my opinion. So I like to suppress because I use the bird analogy. So I can suppress your brain from sending out FSH by giving you estrogen, progesterone, testosterone, ovulation blockers, a medication called Lupron, which is a GnRH agonist, the birth control pill, and combinations of the above. So if I can starve those follicles and then stimulate them, I find that we get a better cohort the majority of the time. So number one, this may not be the protocol that's best for you. It could be that they just use an average protocol for a 29-year-old and said, let's do a spontaneous antagonist start. And that wasn't the best thing for you because with a lower AMH, you're not an average 29-year-old. But maybe they did the perfect protocol and they did the suppression. What's also super interesting is that, yes, eggs are at different stages of maturity. I like to think about them as a GV, germinal vesicle, not mature at all. And M1 has completed the first stage of meiosis and it is close to maturity. M2, what we consider a mature egg, has completed the second stage of meiosis and can be fertilized. And then on the other end is almost a degenerated egg, which is overcooked, for lack of a better word. In general, the mature range, when I am measuring your follicles, is going to be about 14 to 15 to 20 to 21. Everybody's got a unique mature range. And I definitely have had patients that had 17 follicles between 15 to 20, and I think we're going to get 17 eggs. Lo and behold, when we go in and we get each one, they're actually not all mature. I have a high number of immature eggs, and that could be that 15s or 16s weren't mature in that person. And that tells us that if we do another cycle, you might be somebody who matures your eggs at a bigger follicle size. So what were the sizes? Number two, what was the range of maturity? Were they immature? Were they overmature? So how many GVs, M1s, M2s, and degenerated did you have? Because you can also have too many that got pushed too big. Same problem. If you have a lot of M1s, those are very, very close. Sometimes just like a longer trigger interval. So clinics actually do different times from the time you take your trigger, which is supposed to initiate meiosis, until when you do the egg retrieval. So I will add 30 minutes if I have a lot of M1s. Isn't that crazy? 30 minutes can make a difference. Yet in some people, 30 minutes, they'll ovulate. So another reason why somebody might have 17 going into retrieval and come out with 11, not your case, because it sounds like you got 17 eggs, but only 11 were mature. But sometimes you go in expecting a higher number and you could have started to ovulate. So the body is very interesting. The other thing that can help us gauge maturity is the estrogen level. So each mature egg should make about 150 to 200 of estrogen. And everybody is different. There are some things that can interfere with estrogen. Number one is biotin. So actually taking high levels of biotin does not interfere with your body's production of estrogen, but it actually interferes with the hormone assay. So it binds to the test. So your estrogen looks different than what it really is. So biotin's so popular and common. We see it in greens and hair, skin, and nails and collagens. But no, only take biotin in a prenatal, no other biotin sources if you're going through IVF or egg freezing. The short answer is 11 mature eggs at your age is really excellent. However, might you want more over the course of your life? You might, depending on if you have a partner or when you might be ready to start that family and how many kids you want to have. I always think this is where a good conversation with your doctor, who can look over the embryology records and look at the sizes and the estrogen and the lab report about how mature they were or weren't, to make a game plan for what they would do different the next time. So again, it could be changing the protocol, changing the type of suppression, changing the dose of medication. Sometimes they start out too low and they stair step it up. And the reverse approach, I like to start higher and stair step it down. Sometimes we see that if you're on an antagonist cycle, when you introduce that ovulation blocker, halts a whole group of smaller eggs. So a different protocol, a Lupron-based protocol, might be more effective. What was the suppression? Was it too long, too little, none? Could it be better? What was the maturity at the retrieval? What were the size of the follicles? What was the length of time from the trigger? What was the estrogen level? Oh my gosh, so many things. That's why REI is a crazy field. but you can do so much with that data. So congratulations on having 11 eggs frozen. That's wonderful. And it's nothing that you did to cause only 11 out of 17 to be mature, but now it's something that we know. And it doesn't mean that you're going to have a hard time getting pregnant in the future. So I don't want you to think that. Having a different maturity range is not going to impact your rates of natural fertility or your ability to get pregnant or the rate of infertility. But it definitely could be an important variable if you are ever doing IVF or freezing your eggs again. And so would have somebody who has access to that data look through it all so that you can be an advocate for your own health and your fertility. But ultimately, great job, Jenna. All right, and now for our last question.
Hi, Natalie. I'm a really big fan of your podcast. I've been listening for over a year now during our Trying to Conceive journey, so I really appreciate all the information you put out. My question today, it was recommended that I take inositol, Myo, and Chiro D-inositol, as well as CoQ10 and resveratrol, all for ovarian support and fertility. I'm just wondering, what are your thoughts on all three of these supplements? I finally, luckily, gotten a positive pregnancy test, and I was just curious about recommendations on if I should continue taking these, and if so, kind of how many milligrams per day would be a safe recommendation. My OBGYN mentions just to continue my prenatal vitamin, but I feel like they're not well-versed in exactly these supplements that I'm taking. So I'm going to hold off, but I was just really looking for some information on that. Thank you so much. Bye-bye.
All right, well, this is a great question, and congratulations on your pregnancy. I actually have my patients stop almost all of their additional fertility supplements when they get pregnant. So my recommendations for pregnancy include prenatal vitamin with folic acid, 400 micrograms at least, vitamin D, 1000 IUs, and omega-3 fatty acids, so DHA or EPA, sourced depending on what you tolerate. Now, that's what I recommend leading into a pregnancy. That's what I have my patients who are doing transfers on unless there's an unusual circumstance. I don't keep people on CoQ10, and I typically take people off of inositol. Now, there is a debate on inositol potentially reducing the risk of gestational diabetes if somebody is high risk for this. Certainly, metformin is a little bit more studied. That being said, were you recommended to take inositol because you have PCOS, because you have insulin resistance, because you're a little overweight? If so, you might want to talk about your risk of gestational diabetes with your OBGYN and see if inositol is the best choice or potentially metformin. If it was just a blanket statement by your fertility doctor, some people do just put everybody on it for egg quality. That's not my jam. I like to target egg quality supplements for disease or patient state. But if it was just for egg quality, then there's no need to be on it. Again, because it's a pseudo vitamin, it's not been studied safe in pregnancy. Even though there's been observational studies and people who've been using it, you're not going to have a big study that is going to come out and say, oh, this is pregnancy class A or B or C. So I always say simpler is better. When it comes to being pregnant, we want to have less things that could potentially cause a problem. So that one would talk to your OB about specifically if you're at risk for gestational diabetes and is this the right thing to do? Is metformin better? Is something else better? If that's the case, should you get tested early, etc.? I would stop the other ones and make sure you're taking prenatal omega-3s and taking vitamin D. Congratulations. I hope this episode was helpful for you. Please call and leave your voicemails in the future so that I can answer your question. It means so much to me, and I just really love understanding what questions you have. So episodes like this, where it is just questions you should know the answers to, things that are hard to find out, I'm here to simplify it. That's my passion. So you can call 657-229-3672. Again, 657-229-3672. You can also leave questions on Instagram at nataliecrawfordmd on Monday, or sign up for the newsletter, nataliecrawfordmd.com/newsletter. Thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd, and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.